Assalamu alaikum. My name is Fatma Ali, roll number 65. I am from 5th Prof Morning and my topic of presentation is benzyl penicillin. First of all, we will discuss about mechanism of action. Benzyl penicillin is also known as penicillin G. It is a narrow spectrum bactericidal penicillin antibiotics. It binds to penicillin binding protein, thereby interfering with bacterial cell wall, peptidoglycan synthesis and resulting in cell lysis. Now we will discuss about indication and restrictions. For use in the treatment of severe infection caused by penicillin G susceptible microorganism when rapid and high penicillin level are required, such as in the treatment of septicemia, meningitis, pericarditis, endocarditis, and severe pneumonia. Resistance is most commonly secondary to the inactivation of benzyl penicillin by bacterially derived beta-lactamase. Contraindications. It is contraindicated in patients with a history of high risk allergy to penicillin. Now we will discuss about side effects, which includes diarrhea, seizures, and allergic reaction, including anaphylaxis. It is not recommended in those with a history of penicillin allergy. Now we will discuss about dosage form and doses. Penicillin G is available as salt for oral and parenteral administration and as repository salt for intramuscular injection because penicillin G is unstable in acid. Here are the dosage form and their doses. It is available in oral dosage form, which includes oral solution, oral suspension, and tablets. And here are the dose range. It is also available as benzathine injection dosage form, and these are the dose range. It is also available as injection dosage form, which includes potassium and sodium salt, and these are the dose range. It is also available as cocaine injection dosage form, and here is the dose range. Now, dose adjustment, which may be required in the case of impaired renal function, and to calculate the estimated glomerular filtration rate, we use Short's formula. Which is EGFR is equals to 36.5 multiplied by height in centimeter upon serum creatinine in micromole per liter. If we have creatinine clearance greater than 50 ml per minute, then there is no need for dose adjustment, but we have creatinine clearance in the range of 10 to 50 ml per minute, then 70% dose at the normal dosing interval is required. If we have creatinine clearance less than 10 ml per minute, then 20 to 50% dose at the normal dosing interval is required. No dose adjustment is required in the patient with hepatic impairment. Now we will discuss about irrational use. Do not administer to penicillin allergic patients. Administer with caution to patient allergic to cephalosporin and renal impairment. It may cause GI disturbance, pain at injection site, anemia, allergic reaction, and sometimes severe Jarisch-Herxheimer reaction. In patient with cephalus, convulsions in the event of rapid IV injection, high dosages, or renal impairment. Do not combine with methotrexate. Rapid IV injection of large doses may cause seizures and electrolyte balance. Now, infections. It may infect with other medications like IV aminoglycoside antibiotics are inactivated by IV penicillin and cephalosporins. Aminoglycoside antibiotics are rapidly bactericidal and should be administered first. The line should then be flushed well with the compatible fluid before benzyl penicillin is administered. Benzyl penicillin may inhibit methotrexate excretion and may result in excessive methotrexate level. So monitor methotrexate level closely. Large doses of penicillin may affect platelet aggregation and prolong bleeding time. Care should be taken when used in conjunction with other medication that may affect the clotting process. Now we will discuss about drug toxicity and treatment. The following intervention may be used to treat the symptoms of an allergic reaction to penicillin. Withdrawal of the drug. If you have penicillin allergy, discontinue the drug. It is the first step in treatment. Antihistamine. Doctor may prescribe an antihistamine or recommend an over-the-counter antihistamine such as diphenhydramine that can block immune system chemical activity during an allergic reaction. Corticosteroid, either oral or injected corticosteroid, may be used to treat the inflammation associated with more serious reaction. Treatment of anaphylaxis. Anaphylaxis required an immediate epinephrine injection, as well as hospital care to maintain blood pressure and support breathing. Now we will discuss about alternative drugs, which includes tetracycline, quinolones, macrolides, aminoglycosides, and glycopeptides. That are these all are unrelated to penicillin and are safe to use in the penicillin allergic patient. Amoxicillin and ceftriaxone are as also used as treatment alternative to penicillin. Now we will discuss about alternative brand, which are Benza and Benzybiotic, Biotic P, and their trade price and retail price are same. Now we will discuss about case study. A 24-year-old woman present to the emergency department with the chief complaint of headache, painful and stiff neck, nausea and vomiting. The patient was febrile, temperature is 38 degrees Celsius, mildly bradycardia, pulse rate is 80 bpm, borderline hypertensive, blood pressure is 140 by 80, with neck stiffness and a positive Brodzinski sign. Laboratory analysis revealed the following: WBC count 22,000 per millimeter cube with 89% neutrophils, BUN 45 mg per dl, and SRCR 4.5 mg per dl. A lumbar puncture revealed CSF with a WBC count of 2,000 per millimeter cube, 90% polymorphonuclear neutrophils, a glucose concentration of 36 mg per dl, and a protein concentration of 280 mg per dl. Gram-positive diplococci were seen on CSF smear. On diagnosis, it is observed that the patient is having meningococcal meningitis. Now subject, gender is female, age 24 years old, symptoms headache, painful and stiff neck, nausea and vomiting. Past medical history of patient. 2 years ago, the patient presented twice to the emergency department over a 2-week period with clinical signs and symptoms suggestive of meningitis. Laboratory investigation of her cerebrospinal fluid showed decreased glucose and increased total protein, findings suggestive of bacterial meningitis. However, the CSF cell count was low and no bacterial growth was obtained. Antibiotics were administered to the patient and the patient was discharged. Now, drug history. No current history of any medication, drug of abuse, or therapeutic drugs. No other drugs history was noted apart from ceftriaxone and antibiotics augmentin, gentamicin, and chloramphenicol taken at various times following her earlier admission to emergency department. Now, object. These are the laboratory analysis which shows WBC is 22,000 per millimeter cube, BUN is 45 mg per dl, which is more than the normal range. SRCR is 4.4 mg per dl, which is more than the normal range. Now CSF shows the turbid appearance. Cell count is 2,000. Glucose is 36 mg per dl, which is less than normal range, and protein is 280 mg per dl, which is more than normal range. Now vital signs shows temperature is 38 degrees Celsius, pulse rate is 80 bpm, blood pressure is 140 by 80 mm per Hg. Assessment: the markedly increased CSF nucleated cell, 90% polymorphonuclear leukocytes. When coupled with the patients presenting sign meningeal inflammation and symptoms like headache, recurrent and febrile attack are suggestive of meningitis, the increased CSF total protein and decreased glucose concentration are consistent with the bacterial meningitis. On CSF smear, gram-positive diplococci were seen, on which a diagnosis of meningococcal meningitis is made. Plan. Meningococcal meningitis can be treated with 20 to 24 million units of IV penicillin G every 2 hours in divided dose depending upon severity. So the recommended dose of penicillin G for this patient is 24 million units per day as 2 million units every 2 hours. Thank you.